Welcome, everyone. It is my absolute privilege today to introduce our Grand Round speaker, Dr. Richard Keene. Interestingly enough, he's here in South Dakota because he owns a family farm out by Mitchell. His parents were both born and raised in South Dakota. He originally was born and raised near Minneapolis and moved to Chicago at the age of 10. But again, is here for the purpose of pheasant hunting and was nice enough to stop in Sioux Falls to give grand rounds and teach some vascular simulation today. Once he was in Chicago, he stayed there. So he did his undergraduate studies at the University of Chicago, followed by med school at the University of Illinois, followed by a general surgery residency at UIC, followed by vascular fellowship at Northwestern, and he has been dedicated to the care of vascular surgery patients at Cook County Hospital since finishing his vascular fellowship. So I came to know Dr. Keene in 2001. He taught me everything I know in 3 different rotations on vascular surgery at Cook County. It is a very challenging patient population. I think Tuesday clinics were approximately 150 patients that would all show up at about 6 or 7 a.m. And clinic just went until you were done. So again, has been a wonderful advocate for resident education throughout all of his years at Cook County Hospital. He became the chair of the Department of Surgery at Cook County as well as Provident, which is another county system hospital, back in, I believe, 2005 or 2006. As residents, you're not always aware of a lot of the things not going right in administration, but things were not going well in the Department of Surgery at Cook County, and as a chief resident, we were even becoming aware of those issues, and all of a sudden one day, the current surgical administration disappeared, and Dr. Keene was so kind to take over as the interim chair. And note that now 12 years later, he's still the chair of the department, and truly turned things around and made it a even more wonderful place to train. He's also the co-director of the Rush and Cook County Hospital Integrated General Surgery Residency Program. He has obviously numerous publications of book chapters and presentations. So again, without further ado, I'd like to introduce Dr. Richard Keene.
So thanks everybody. Is that loud enough? That's okay. Yeah, so obviously when Mel came to Chicago, I was immediately interacting with her because most people, as my mother would say, people that come from South Dakota usually you see them. So that's a South Dakota joke. But this is a real treat because when I say my earliest memories, I was discussing last night, my earliest memories as a child were driving from Minneapolis, South Dakota. My father was working my grandparents' farm. Because his father died young, and my father was basically working in Minneapolis and running a farm 300 miles away. So a lot of times you can't see the effort that goes into building a lot of things. And one of my issues with surgery, which I think I've heard it actually echoed by Dr. Johnson and Dr. Timmerman and staff, is it takes a lot of work behind the scenes. And when you see a master surgeon, you don't necessarily see, you see the skill and you see the knowledge, but what you don't see is all the work that went into that. So no one's gifted, no one's born natural. It's just a lot of very, very hard work. So let's just get started here. So thank you very much. This is a real treat, and I really appreciate the invite to come here. So this is not a Photoshop. This is from the movie The Fugitive with Harrison Ford. The offer, just outside, the offer was made for University of Chicago to be the hospital that they used for this movie. They turned it down because they didn't think it would be good for their image. And I have other names for University of Chicago. Since I went to college there, I could rip them. But they turned it down, and little did they know that this was turned into a classic movie. So another interesting one, when I started as attending, Princess Diana, when she came to the United States, she came to one hospital, and that was County Hospital. So there's some history here, and so I'm going to talk about a couple things, just to kind of tailor it. Originally, I was going to talk about just vascular trauma, but I thought that was always too narrow. So I'm going to talk about limb pain, just to start, because this really touches everything. You're going to be called to see people for swollen limbs, painful limbs as a general surgeon, and I'm just going to run through those things to sort those through what do you do? And there's catastrophic things, there's simple things. So just talk about history of limb pain. John Murphy, Murphy Auditorium is one of the founders of the American College of Surgeons. He was a staff surgeon at Cook County Hospital. He started surgical clinics in North America. It was originally Murphy's Clinics, and the first 29-year-old patient in a gunshot wound, of course, in Chicago, in Cook County Hospital. So, as Ben knows, and from rotating, that's how did you rotate at the county?
Yes.
Yeah, so you know now. It's a that was the first case of an arterial resection and repair was a gunshot wound at Cook County Hospital on a 29-year-old man. And Murphy did experimental work that basically invented triangulation for basically 120 degrees apart circumferentially to 3 separate suture lines, running suture lines, which was the basis for the Corral patch and for transplantation. So this started with Murphy in the 1890s. And then the first case was at County Hospital. So let's talk about extremity pain. It can be a limb or life-threatening problem, and that's what you worry about. It's not like the chest pain where everybody thinks of the Levine sign, where chest pain, a hole in their chest. Most common, so that's the association with chest pain, but extremity pain, it's usually not something that's like that. It's usually something, usually musculoskeletal or something else. But if it's missed, the problem is when it's missed, in retrospect, it's moderately obvious. And so that's what we're talking about with permanent limb loss or disability. Let's say most things are not limb-threatening, and most pain issues are self-inflicted from either overuse, soft tissue trauma, leg fatigue. So that's what you look for. And the pre-critical things are basically related to tenderness, confirming by history. And that's what I see. I routinely see on Monday night, I saw somebody who sent it to me just to evaluate, is this a vascular problem, yes or no? So you want to sort those out because those are the catastrophic ones. As I like to say with the medical students, between us and rocks, the difference between us and rocks is blood flow. And so when that's compromised, either coming in or going out, you're going to have problems. So frequency, traumatic is the most common problem, orthopedic problems, neurologic problems, nerve root, inflammatory, which is infectious, neurologic, or the vascular problems. And you want basically those are the 4 categories. You want to sort it out and try to figure out what it is to make your diagnosis. That will decide your treatment. So we were looking at trauma or mechanical issues. It's either joint swelling, effusions, crepitance, muscle atrophy with inflammatory issues. It's joint swelling or soft tissue edema or crepitance. And the vascular issues obviously comes down to pulse exam, to very simply doing a pulse exam, doing a good pulse exam and peripheral. When I see a patient for the first time and evaluate them, and it's not clear what's going on, I start with the palpate femoral pulses. It doesn't really good to go distally first because it's not going to, if they don't have femoral pulses, they're not going to feel pulses. So if they don't have femoral pulses, then you know there's a problem that's substantial, higher than that. So we'll start with that. And then the physical finding exam of pallor and palate elevation, lumbar. The picture I'm showing is someone who actually has Plateau syndrome going after emboli. So they'll have tenderness on exam. There's only a couple things that cause tenderness in the foot. So ischemia per se doesn't cause tenderness. It's the reason atheremboli will cause tenderness is actually the cholesterol that is embolized from a plaque causes a vasculitis, an inflammatory reaction. So the other things that cause tenderness are infection, when you're feeling like a tenderfoot. It's an infection, gout, or atheremboli, when you see changes with that, and it's from local ischemia and actually a vasculitis from an immunologic reaction with cholesterol. So you'll see this redness. And there may be a saying in this case, the person had a, shows, but there's the patient had a palpable pulse on the, patient had actually a palpable pulse in their foot with this finding of ischemia. This is venous findings. The gator region refers to gaiters, which people use for skiing to cover between their ankles and their knees. And that's where you'll see the change with venous insufficiency. The reason that a lot of times vascular surgeons take care of venous disease, you wonder, like, why do vascular surgeons take care of venous disease? Because anybody can probably take care of those wounds. And general surgeons can take care of those wounds. What will happen is there's a small group of those patients who need vascular operations. So that's the reason surgeons really take care of those, is you'll sort through the ones. The rule I learned from John Bergen, who was actually started his career at Cook County Hospital and was chair of vascular at Northwestern. Eventually, as he would, his teaching was no edema, no ulcer. So the key to treating the venous ulcers is you get rid of the edema. So that means I tell patients to lay on the floor with their legs elevated an hour a day. Some of them can't get, they said, Doc, I can't get up if I lay on the floor. So you kind of have to selectively use that. But elevation is absolutely key in compression. So it's a compliance issue. So I use Una boots whenever I can. Una boots are a method that stops the leg from swelling, the force of the compression. There's just a little bit of contraction with the Una boots. And they're cheap, they're less than $1. I've also learned from patients who have trouble buying them. I've had them on for as long as 5 weeks at a time. I'll put a betadine gauze on the wound, especially if ones that can't travel or they can't really change them themselves. But I've learned that's kind of the limit. I've learned 5 weeks is as long. 6 weeks, they tend to be a problem. But you can leave them on for a long time, just like a cast. And the advantage of that, you don't have to change them as frequently as twice a week is the way I was brought up to do it. And it works. So once you get rid of the edema, the ulcer will heal. If it doesn't heal, that's a warning sign that there's a problem, that there's going to be some type of intervention. So the key to wound healing is you need an AV gradient, you need a pressure gradient for oxygen to deliver. In other words, you need arterial pressure and venous pressure have to be different. The problem when you have, if you have venous insufficiency or venous obstruction, the venous pressure elevates, you don't have a big enough AV gradient for oxygen to get oxygen delivery. And also, as you get edema in the tissues, what that does is it obstructs the small vein walls and obstructs circulation. So you can either have edema in the tissue or you can have your veins. You want a lot of veins because you want that permits arterial blood to get through. I think of like veins as like your sink, like your drain of your sink is really what the venous system is. And if that's obstructed, just like if your sink is clogged, it's not going to work. You can't wash dishes, although I don't want to wash the dishes anymore, right? It's all dishwasher. So the key there is if you get rid of the edema, that opens up vein walls so that arterial blood can go through, drop off oxygen, and heal. So that's why you get rid of the edema. That's what's going on. So if you have obstruction, so either the venous pressure is elevated, either there's venous obstruction, and that's when we bring venous bypasses, or which are indicated. Sometimes just elevate venous pressure from reflux, where we'll do vein procedures to obliterate veins from venous occlusion. And there are some patients where they'll have single vessel arterial disease. Usually, a lot of times, single vessel arterial disease, like femoral artery occlusion, we won't treat those if they just claudicate, if people can tolerate it. But if they have venous disease and ulcers don't heal, then we'll intervene on those. So what it does is when you get rid of the edema, that will sort out the patients of who you need to do some type of intervention. So just basically the danger signals are future occlusion, venous thrombosis, phlebitis, that pain from the groin, these are the kind of bad ones that you basically comes down to physical exam. So vascular is the one especially where you still got to get the people undressed and you got to look at them and palpate things to really, you can't just CT it. A lot of stuff you figure out from history and physicals, like the last physical diagnosis, where it still will give you more information than any other testing that you can do. The difficulty, now I say trauma is the most common cause of acute pain, so just the question of really getting the history in terms of sorting that out. One common thing, sometimes we're called just to see swollen, as a general surgeon, we're called to see them with a swollen limb. And you're trying to figure out what's the cause. It's a swollen limb, what's the problem? And they'll just call for that issue. The first place that I'll look is actually, I'll look at the foot. So why would I look at the foot if they're called for a swollen limb? Anybody know why is that critical? Or if they have a swollen arm, I'll look at the hand. Call for a swollen limb. And they're basically trying to start out, is it lymphatic, is it venous? You can figure out, is it color?
Based on the color.
Somewhat, well, color, if it's purple, then it's going to be like phlegmasia. That will tell you it's a DVT, if it's venous congestion. So yeah, so you can pick that up. The other thing you can see is that if it's lymphatic obstruction, you'll have swelling of the hand and the foot. But with venous obstruction, usually the hand and the foot are spare. So that's something you can just look at them, you can eyeball them. You can pull back the covers, look at the extremity, the leg's swollen but the foot's not, then it's a venous obstruction, DVT. You don't see the lymphatic swelling until later if it's a chronic problem. So you can sort that out just without even doing any tests. And you get a diagnostic test to confirm it, but you know what the diagnosis is just looking. Okay, this was a bullet emboli. So obviously more dramatic source of acute limb pain. The usually associated with multiple other soft tissue injuries. We've started seeing assault weapons in Chicago in the last 2 months, which is a complete game changer that, in terms of how to deal with that, because the soft tissue injuries are unbelievable. So I brought that up. The difference with the bullets, with simple bullets, is it's usually a hole the size of your finger, and so what's actually injured is limited. But with assault rifles, it's like you put your hand in the wound. And one of my partners had, well, I'll tell you a little more, but this is actually, the bullet was actually, you can barely see it, well, you can see it here, but the bullet was actually inside, perforated one side of the artery, and then actually lies in the middle. And we took it out. These are 2 pictures side by side. So obviously that would be acute limb pain. Obviously stabilizing is the most important thing when there's associated fractures. And a lot of times there's pulse deficits that will return if you're able to just stabilize the fracture. And then now with the beauty of multi-detector CTs, determining if there's an issue or not, the time we have to use actually diagnostic angio to figure out what's going on is much less. So routine is very important. So part of that is just one reason they do trial protocols. It's just that you don't miss anything, you don't get excited. I remember my first day of medical school was a video of a trauma. On this, I did my first year of medical school in Champaign, Illinois, which is central Illinois rural area. And I remember the moderator on the video said, "Remember, it's not your blood." And I've always remembered that, right? Like you get squeamish or remember, it's not you. Take this out-of-body experience. Just deal with it. So routine, palpate everything, especially because sometimes if there's head trauma, which is probably about 30% of the patients have some degree of head trauma, they're not going to be able to tell you everything. And that's when you get in trouble with acute vascular problems, when people can't complain of the symptoms. You got to be really, really aware. Doppler, if I was on a desert island, I had choice between palpating and using a Doppler. I take the Doppler because you can palpate your own pulses. There's one of my residents, we used to, I think predated Dr. Johnson, but I had a third-year resident who could feel pulses on everybody. And so my chief one day, I think it was probably first, second year, he goes, Drex, you know what we're going to do? We're going to go down to the morgue on Saturday because we're going to feel some pulses down in the morgue. So actually now the pulses, we actually call it, after that resident, those pulses, when someone palpates resident or junior resident or student palpates pulses and someone has no pulses, I'm not going to say the person's name, but Dr. X's pulses. You don't want anything named after you like that, okay? Okay, nerve root pain, obviously things like the devil's claw from severe pain associated with virus infections and temporality, but nerve root pain is a little more trickier to sort out because a lot of times the nerve pain is associated, especially with the diabetics, long-term diabetics, it's difficult to sort out vascular rest pain from diabetic neuropathy. It can be very tricky. So like the shingles is the other one for devil's claw. That can present initially as pain. Burn the needles, distal predominantly. It's constant pain. Usually the vascular is associated with use unless it's really rest pain. Inflammatory pain, infection. Those are the other things that can be somewhat protean and difficult to sort out as a surgeon. But the things you look at it as a surgeon, the things you really worry about are infectious problems and usually ischemic blood flow problems. So rheumatologic and infectious, I put the emphasis on the infectious component. So the Greek roots dolor, tumor, calor, and rubor relate to inflammation. This was a case of one of my patients who actually had contact dermatitis from vitamin E ointment. Thought that would help their discomfort, which is topical dermatitis. So the same way, looking at the skin, examining that, sometimes you can sort out is it infectious? Really sorting out is it infectious or not, and looking at all the factors that decide that. Extremity infections, you tend to see things cellulitis is being consulted a lot. We still can, as a general surgeon, consult with cellulitis because you shouldn't get upset about those consults because it may not be a surgical problem, but at least the individuals who are seeing this are concerned enough. You don't want to miss something that's a necrotizing soft tissue infection with a factual infection from the strep. Strep is the most common cause of cellulitis. It's also the most common cause of necrotizing soft tissue infection, meaning it's gotten through the fat onto the fascia and just travels, just like it's on the interstate, travels up underneath the subcutaneous tissue and causes havoc. And we routinely see, all of us have seen cases where it's been neglected or missed. So cellulitis is important. Sometimes there's breaking the skin, sometimes there's not. So be very, very aware of this. I can still remember a case where I was a transplant patient who had erysipelas in the legs, and it didn't seem that bad, but they died within 24 hours. So it can just be rip-roaring. I can remember sitting on seeing someone with a perineal, distal thigh perineal infection. It was at 2 in the morning. Thought, oh, we'll just take care of this in the morning, and you go to sleep for 3 hours and you get up. I was like, oh my God, I can't believe how much it's progressed. So there's the suspicion and index and assume it's going to get worse when you don't have multiple data points that you really want to act quickly. So cellulitis, painful, tender, septic arthritis, usually, or sometimes orthopedic surgeons they're not interested in that. So you'll be involved in those cases, and it's a lot of questions trying to sort out. Usually with joint motion and tenderness, when you're trying to sort it out, there's times I've had to call the orthopedic and colleagues and say, hey, they may have no interest in the case, and then we'll get called for an extremity issue, and we'll say, well, actually it's a joint knee, septic knee, or septic hip. There's cases where we've had to call the orthopedic surgeons back to look at that. So that's really part of your role as a general surgeon to kind of sort through all this. There is nobody who really understands, I would say, peripheral soft tissue infections other than the general surgeon, because no one else really is interested in these things. And a lot of times patients are very, very sick, and especially think about orthopedic surgeons, they have no interest in taking care of anybody who's really sick. Like they just said, like if it's sick, that's a contraindication for orthopedic surgeons to be involved with their care. So, and a lot of times extremity cases there, they don't want to deal with that. They want to deal with just joint implants, even though it's extremity. So it really behooves general surgeons to be actively involved in those cases and take care of them, because otherwise they're relatively orphaned. And even in our setting, cases get neglected. So you just jump on those. So they say it's usually the general surgeon usually is the best one to understands the antibiotics better for treating abdominal surgical infections. A lot of times it's the same things, sexual debridement. And also I think sometimes the back gets overused here. If you actually read about the back has been revolutionary in terms of medical care, but 30% of cases where you use the back it fails treatment. And so 30%, that seems like a pretty high failure rate for back, but it's infection and ischemia are the two contraindications if you actually look at it. So you got to be judicious how you do it. Because what you're doing is you're creating an anaerobic environment. So actually you're kind of creating a perfect culture environment. So open wounds and wound care is a little more work, but it's the better way to handle some of these cases. So just bring it up. So this, in summary then, 7 surgery scenarios: vascular trauma, ischemia, venous obstruction, acute post-op pain, specifically related to placing access. There can be acute pain, you got to sort that out, which has now become one of the most common vascular operations now. It's maybe access for dialysis. It's renal failure is an epidemic in this country, and there's not enough kidneys to deal with that. And I think we're ways away before we have artificial kidneys. Compartment syndromes, surgical infection, neurologic symptoms are I'd say the 7 acute limb things that involve surgical intervention. I'll run these pretty quickly. Mechanical overload, pain, swelling, ecchymosis for vascular trauma. When there's a fracture, be suspicious that there's a vessel injury. If there's enough trauma to break a bone, there's enough trauma to injure a blood vessel. The tight end of the Bears was at a knee dislocation. Zach Miller, he was down actually in New Orleans, and he had an anterior dislocation, and at least it was recognized immediately that he had arterial occlusion. He had a popped artery rupture. that required urgent intervention. And I'm sure compartment syndrome and the difficulty with some of the determining traumas, like I say, is if the person has a head injury and they don't complain about it. People complain about pain, as we are. People always complain about pain in patients, but if they have a mental, some type of head trauma, they don't complain. That's how things get missed. The sheets are covered up, you miss it. So you got to be very, very suspicious of that. Popliteal artery injuries related to knee dislocations was the number one source of litigation for orthopedic surgeons for a number of years. So it's something, if you miss it, when you have x-rays like this, it's from a posterior knee dislocation. Sometimes it's hard to remember, is it a posterior knee dislocation or is it an anterior knee dislocation, which one? It refers to where the tibia is. So the tibia is, in this particular case, the tibia is being displaced posterior. So this is posterior knee dislocation. Exam is critical. There's the exam that's done is actually called sometimes when you see them presenting in the emergency room or in the trauma setting, sometimes the knee's reduced spontaneously, sometimes it hasn't been. A lot of times associated with bumper injuries, people look like cars, or athletic, where they hit the bumper and then this posterior knee dislocation. Or sometimes I've seen big people walk off steps, they slip on a step, and that's enough to dislocate the knee. And it's somewhat random who gets a vascular injury and who doesn't, but you have to be suspicious for that. So between MR and CT, it's critical to identify that there is an injury. You don't have to intervene on all of them, but you have to at least have that suspicion. So it's a very, very high complication rate. The nerve, surprisingly, usually doesn't get, even though the nerve is right there too, it usually doesn't get stretched. The nerve system doesn't use bad, but you have chronic instability, arthritis, but if the arterial injury is missed, and usually it develops, there's acute compartment syndrome and acute ischemia, it's not recognized, the amputation rate can be as high as 10%. So open injury versus closed. Diagnosis on x-ray, you always have to have either anterior or posterior cruciate ligament. One of those two is going to be torn, along with the collateral ligament, to get an unstable knee. The exam is called a drawer sign, where you basically pull, just like you're opening a drawer, you pull the knee forward, it's an anterior dislocation, you push it backwards, pushing it as a posterior dislocation. But acutely, the patients, but it'll be an unstable. If the knee is not locked and if the injury is reduced, you can do that. You'll see that laxity without, which is what you'll see the orthopedic surgeons do it. You can do that exam yourself too. So the posterior drawer pushing in, and then the anterior door pushing the other mechanism with the one hand holding the femur and the opposite hand holding. That's how you do the drawer side to check for anterior dislocation. Regardless, this injury is missed a lot, so and I say much litigation. It's about 30% of the time there's a vascular injury. With the anterior dislocations, there's usually a stretch of the popliteal artery and internal injury, and so sometimes they'll present delayed. They'll initially have pulses when they come in with an anterior dislocation, and then they'll throb, and they may have they're hit by a car, they were a bumper injury, hit by a car, and they hit their head, and they're obtunded. I can think of a case where it was missed like this. It was just not recognized. It was recognized 48 hours later when the leg was really basically a lost cause. So the posterior dislocations, it's dramatic enough that usually the popliteal artery, remember, is fixed from the soleus below and at the adductor canal above. So posterior dislocations actually can be torn. So reduction, splinting, and then Franken assessment. The ankle brachial index, I think, you can do it. If there's an abnormal index of even 0.9, that suggests some injury, but it's so easy to image now, I think just imaging is what we do. Beware of the warm foot. I'd say just because you feel warm, because it can fool you. And the pulseless, same way, the warm pulseless foot needs to be revascularized. Like I said, even though it's warm, and you can't, spasm is the enemy of limb loss, of limb salvage, is don't trigger something to spasm. And even though you have a pulse exam, you worry that your neural pulses, you just be suspicious, you got to image it somehow, CT or MR. And the ultimate metastasis, they said the ones you can worry about. So knee dislocations, operative approach. There was a study done at County about 1980 by a surgeon named Leo Lin, and Leo Lim, and he actually did 30 cases of pop-tolerant injuries with no limb loss. And so I've tried a number of different ways over the years, and I've decided the best way to deal with pop-tolerant injuries, which we see a lot. We probably see probably 3 a month. We'll see pop-tolerant injuries, and a lot of them transferred in now. And the first thing we do if it's an injury that's been for a period of time is do a fasciotomy. And so they're like, wow, you got an internal injury, why would you do a fasciotomy first? What the fasciotomy does is it lets circulation resume. When you have a swollen extremity, it's almost like a tourniquet, you have warm ischemia. But what the fasciotomy does, it permits venous return, especially if you have with the muscle swollen. If you perfuse the artery without doing a venous return, you're blasting in this arterial blood. So what the fasciotomy does is let the muscle relax, it lets some of the muscle circulation go through. So the fasciotomy is the first thing that we'll do. And if there's a venous injury, I'll do the venous part next. If there's associated venous injury, and then the last thing I'll do is arterial repair. And so what you're doing is the arterial blood's trying to get in, because even from the collaterals, from the knee, it's trying to get down. But remember, once the muscle starts getting swollen, then you lose circulation. You have basically warm ischemia, and the fasciotomy gives you time. So it lets at least some circulation go through. So if you understand the pathology, big swollen muscle, veins are obstructed. By releasing those veins, then you can get some more circulation. So that's the first thing. Chronic arterial insufficiency, talk about that. So chronic arterial insufficiency, we know about those things. I've been asked, like, what does plegal do? For claudication. It helps some patients, but it's a lot of times it's clinically significant, but not. It's statistically significant improvement in walking, but not necessarily clinically significant. Meaning, if you walk 100 feet now, you can walk 115 feet. You can walk further. There's a proven benefit, but it doesn't really make a difference. So, but it's something to try in some patients that are maybe not good arterial candidates. It took a while for me to remember. How do you remember? It's always asked sometimes on your in-service exams about the different ways. The way you remember the P's of acute ischemia is I break them into neurologic and non-neurologic. Everybody on all 120 patients or 150 patients in the vascular clinic all have pulses, pallor, and polar. When you start getting concerned, when you start getting neurologic compromise, which is pain, paresthesia, paralysis. So that's why you break them up and remember. IV heparin is my favorite drug. And it will save you trouble if you remember the 3 rules of role of IV heparin. And usually I have to say this once when something like I'll be talking about something in the emergency room, and then I have to recite this, and I only have to do it one time. How does heparin work? It does a couple of things. Remember, it's a very complex molecule. Low molecular weight heparin kind of gives you that clue. It's a 10 to 50,000 kilodalton protein. It has a lot of effects. The way it works with clotting, why it's so important, is it's like throwing water on the fire. The problem with clot is made up of fibrin, red cells, platelets, and thrombin, which is an active enzyme. So you got to stop that. Think of the case that Kirkham showed earlier, the case of that young woman, or actually it was, Paul showed that case, right, with or was it Ben? Who was the last one? Ben. Yeah, Ben, that kid, Ben that showed. Like, here's that woman had that DVT. Her problem is once she started that DVT that Ben showed, there's nothing to stop it. So that active thrombin makes more clot, makes more thrombin, and there's nothing to stop that. Remember, this is the active thrombin is the enemy. So once you give heparin, that stops the process. So that's why it's so important to give heparin. It stops it from progressing. So usually people come in. So that's why the anticoagulation with Lovenox or IV heparin is so critical, because that basically stops the force fire. It binds with heparin and vitamin 3, and inactivates the active enzyme. Heparin also vasodilates, so we call it voodoo heparin, because I've always had arguments with pharmacists until some of my residents finally found papers that showed low dose heparin actually causes vasodilation. So if a couple comes in the emergency room with ischemia and pain, we put them on heparin overnight, and usually the pain will resolve. And there are papers now that show that actually vasodilates. So it's the high molecular weight fragment of heparin that has that effect. If you give people Lovenox and they have respirate, it doesn't do anything. So I'll put people on low-dose heparin, 400 units an hour when they come to the emergency room with chronic ischemia, and it works. It solves their pain. But it has to be IV drip. Phlebitis, all of us have seen that. Acute inflammation can be managed with non-steroidals. The tricky one with the superficial phlebitis, when you have to worry about it, is if they have a thrombus in the various saphenous vein going up to a level of the groin, saphenofemoral junction, you operate on those and you interrupt that. You do it, or basically you can follow some people with phlebitis with a thrombus in their saphenous vein, but if it goes up to saphenofemoral junction, becomes a DVT, the treatment for that is actually surgical ligation. So to deal with that, and you can follow that on ultrasound. Phlebasia, all of us have seen this. Heparin elevation, and that's once again approved to be a strange, and intervention, either percutaneous or operative, depending on indication, or contraindications, what you can do. But elevation is probably the most important thing. Well, what you'll see sometimes on CAT scans, you'll see a thrombus in the middle. A lot of times, the patients come in, they're dehydrated, and so what you'll see on CAT scan is that there's actually a rim of blood flow around the thrombus. So hydration is very important because you hydrate the veins, you'll improve the circulation because the veins will stretch and the thrombus will contract a little bit. So that's the treatment. Hydration is very, very important. Besides heparin for the reason we talked about. So obstruction, anticoagulation, thrombolysis stent, filter, optic thrombectomy. Percutaneous vascular injuries. I'm seeing more and more of this. We had, because of all the things you can do with small devices, and you see complications related to that. So groin access, we're seeing a run. We had a run of patients come in with infected femoral arteries. Couldn't really figure it out because the patients, one patient came with a big, kind of massive soft tissue infection. Couldn't figure out where it had come from. And it turns out he never had a cath, but he had a massive soft tissue infection, affected the artery, affected the vein, big necrotic soft tissue infection. It turned out he had, the ER was on their latest thing to get people with difficult blood draws. They're doing primary femoral artery sticks for their phlebotomy for ER evaluations. And we had 3 patients who came in, were just basically, it's the easy way to get blood, right? You know, it's the way to deal with the problem. They were just sticking femoral arteries to get access. Trauma surgeons, you've seen trauma surgeons do it a lot, and just like, please, okay, just, I know you're not going to, you get your blood done, but you know, a couple days later, then you know a whole other separate problem. So it's, just beware of that. It just, the vessel get infected, it's a problem. Arterial fistula, thrombosis, a lot of things have to be fixed open. Knee arthroscopy, I mean, I've got a couple of patients who've had catastrophic situations where having knee replacements and then it's not recognized right away, and you have to have a high level of suspicion. Arteries transected, so what about that? Arthroscopy, stripping of veins. I can say one time I was taking care of it was the wife of one of the Chicago Blackhawks, and you know, sometimes you got to be, the anatomy can be a little bit different, and you got to be really, really wary. Sometimes there's aberrant locations, using real big veins. Sometimes people use strippers, and there was a case I took care of from someone else that they had stripped the common femoral vein. So it was, because it may insert abnormally low, and especially in thin patients, sometimes it's not well obvious. So you got to be really, really, really wary. Iatrogenic vascular injuries cause problems. We have a case of nephrectomy where got into bleeding. The big problem when you have intra-abdominal bleeding that I think is forgotten is what you can't sew. When you get into bleeding, the thing to remember is you got to clamp the artery before you just start sewing it. You can't you can't just sew bleeding vessels because the pulsations will cause it to tear. So you've got to clamp things. And when you get into bleeding, it can be a panic mode, unexpected, and people start sewing, but the hole gets bigger if you don't clamp above that. And so this was a case, we had a patient, they were doing a nephrectomy, and they finally got the bleeding stopped, but they ligated the aorta. And got the bleeding stopped, and the patient complained of lower extremity pain, and they couldn't figure out what it was, but it was in fact severe ischemia. So ended up with viral amputations by the time we were consulted. So be careful about that. This is a case, the last one, of a surgeon that Mel and I know very well, was lapping one of our patients, had a previous aortic surgery and then other vascular operations. And bowel obstruction and unzip the abdomen and went right across the bypass. See, that's a big vessel bleeding. I've had another one where sometimes we'll treat SVC syndrome with a prostatic bypass. We'll drain, rather if the SVC is blocked, we'll do a bypass from the axillary vein to the femoral vein to drain through the IVC. And I haven't seen that get kind of transected. See, what's this big thing doing there? Oh, it's just something all over. So, and then their arm blows up, or their head blows up, because it was actually draining that problem. Still syndrome. So access is something, as a big plug, as a general surgeon, please do access because it gives you, it's the most common vascular operation. And it's an epidemic, and you want to take care of these patients. And it gives you the skill set and routine that you can, when you need to do vascular, you can do it. Mostly because of the trauma. So I would recommend that you do access. I'll just make that plug. Everybody should do that when you try to come out. You can get acute still syndromes where they have limb pain right away. Sometimes it's very difficult to diagnose because with the diabetics, it's hard to sort out where the problem's coming from. So but be very, very suspicious of ischemia. I've seen it on day 0, acute ischemia, and always try to, with fistulas, this is not talking fistulas, but you try to come off the radial arteries the way that you're saved. Anytime you go out the radial artery, you have risk for that. This drives my partners bananas because I'll put Dermabond and I'll use nylon. They say you're not supposed to do it, but that's what I do. And my partners hate it, but the reason for that is everybody swells up, and actually I'll do my skin closures very, very loose. I'll do a tight subcutaneous closure. But everybody swells up after doing access. Everybody gets tissue edema. They have a occult central vein obstruction. Arm will swell up. So I wrap it with an ace bandage, but I'll do this with the idea that I can cut the sutures out, and the Dermabond will still hold the skin in place if they swell a lot and the suture line gets edematous and is worried about being compromised. But just talking about the swelling, this was a case where a resident closed this one too tight, and then the skin necrosed and didn't anticipate the swelling. So I always do the skin actually it's like an air knot or a running air knot stitch, so you don't have this problem. But the pain afterwards, for these access, I always see everybody within the first couple days because they can have acute wound problems related to AV access. Usually because if they have a catheter, central venous obstruction is a cult. When you put in the fistula, you increase the flow. The venous flow markedly, probably threefold. So it'll go and mask those things. Gotta be very careful with aberrant anatomy. Median nerve lies deep. Usually you don't see it when you're doing AV fistulas. When you go right above the elbow, this is unusual. This is the case where median nerve is actually on top. And you can easily just think you confuse it for part of bicep tendinosis. You can cut it. They happened to one of my chiefs when I was an intermediate resident to cut median nerve, so beware. This is lithotomy complications are actually somewhat common. With having well-padded stirrups makes a big deal and being suspicious. Usually you see these problems with people who don't have vascular disease. And I think it's happened enough now that most gynecologists, colorectal surgeons perform procedures. They will evaluate the extremities, but you may get called to look at this and say use the Doppler. A lot of times patients are B-scan evaluated, but be suspicious for these cases. Sometimes you can have compartment syndrome without actually arterial injury, and so you may just request a fasciitis. Compartment syndromes are basically, it's usually a ischemic insult. What's underappreciated with compartment syndromes is the median time of when you see compartment syndrome after the insult is about 24 hours. It doesn't happen right away. So it's kind of out of the neighborhood of how soon you would see it or when you expect to see it. Passive stretch and suspicion is the best thing. Palpation, I think, is the best test. I usually I've seen it enough times now that if you're suspicious to do it, it's a relatively simple operation to do. I've done them at the bedside before if you have to, but suspicious for compartment syndrome, especially for anterior non-compartments. But remember, it's usually they ask on the in-service exam, is what's most likely artery to be injured? Does anybody know when you're doing a compartment fasciotomy? Most likely artery to be injured like fasciotomy. So there's 3 choices. Posterior tib, yeah. Posterior tib kind of comes superficial, right where the soleus ends, underneath the fascia. So that's most likely why to be injured. So, and you have to take the soleus off the tibia. You have to basically, a complete fasciotomy, you have to take the soleus off. You have to see the posterior tibial artery. So I'll follow popliteal artery all the way down, follow posterior tibial artery, take the entire soleus off, and then you've done complete fasciotomy. This picture is someone who had actually a clostridial infection of their gastric infection from an abscess from an AV fistula, 95 years old, and so I was seeing the patient every 3 days, and I kept having to read things. I'm going, what's going on here? Because the culture came out relatively late. It was anaerobic culture. I saw her initially post-op, and she had some wound issues. Couldn't figure out what was going on. And later on, then I saw that she actually was gas gangrene, so altered antibiotics, and eventually did fine. But it was like, wound care, this doesn't look right, it's not looking good, I can't figure it out. So when that happens, always be suspicious.
Looks like this is a graft, right?
No, this is AV fistula. So, yeah, so it was a loop fistula. So what we did is, I think initially she had a wrist fistula, and the artery wasn't really good, so we turned it into a loop. Basically, freed up the entire forearm spalpine and turned it into a loop fistula. And that's why it has this configuration, like this. But then you had skin necrosis, and so it happens right away. So eventually, though, she did fine, but it took a lot of just local wound care. Neurologic symptoms. I've had traction injuries to all those, median nerve. The difficulty when you're working above the elbow doing access cases, a lot of times you can put traction on the median nerve. You won't even see it because it's deep. But when you retract the tissues away, you can put traction on the median nerve diabetics. You got to be very, very careful when you're working just above the elbow. I've had femoral nerve injuries from doing FemPops. If I put retractors in deep, you can put traction on the femoral popliteal nerve. And femoral nerve also just up in the groin. About 10% of patients who have cats get actually have injuries to femoral. And something that affects all of us is when you put the arm out 90 degrees on the table, especially both arms, if people have underlying disc disease, you get ulnar nerve problems for long cases. So sometimes positioning, try not to put them all the way at 90 degrees like the cross sign, but try to bring them down a little bit, it takes tension off that ulnar nerve and prevents that complication. When I was at college, I met a vascular surgeon who was going to go work at, just graduated, so he was going to go work at MIPS, Shock Town. And so that's kind of part of the acute care surgery model now, sometimes has vascular surgeons involved as part of that team. My push is for when we don't actually train a vascular fellow at county. We have 8, well now it's going to be 9 general surgeons a year. And I've always got a lot of requests to train have a vascular fellow. And in fact, Rush had a vascular fellow. It's a Rush County residency. I call it the County Rush residency because I'm a little bit biased. But when I went through it was actually a U of I county, but I won't consider myself a county resident. I'm wearing my U of I tie, but I had to start coming with county ties, so like our county diplomas. So, but the question is why I've always had, and actually the Rush had to close they didn't have enough cases that had to close their fellowship, their vascular fellowship. But I always looked at it as like, I want to train 8 safe general surgeons a year, and the way you train part of training a safe general surgeon is learning how to deal with blood vessels and with bleeding. And so I think that's more important than training vascular surgeons per se. Like we launch a lot of individuals. 2 of our chiefs this year are doing vascular fellowships. But part of it is we want to make sure that to be a good, safe general surgeon, even Halstead brought that being able to deal with blood vessels is really a measure of a surgeon. The way you'll get in trouble and as a general surgeon in the operating room is getting the bleeding. Well, if you can deal with bleeding, you're not going to kill anybody in the operating room. That's why this is so important. And so it's really a public health issue. Our emphasis at county has always been on training general surgeons who are very, very safe, that they can deal with trauma, they can deal with bleeding, and it's like the weight training or cross-training surgery is the way I look at vascular. So there's something that when we were just chatting between M&M and now was Dr. Timmerman was about just having the residency. I think you should be very proud of what's been built here because it's actually really, really impressive. The level of discussion is very, very good. But I taught chemistry when I was in medical school. I taught a chemistry course, and so the cover page of the manual was the Latin for Cudos Edici, which is he or she who teaches learns. And so that's what Dr. Timmerman just brought up is once you start getting in an environment where you're actually teaching, you learn. There's also a Jewish proverb, that's the 5 steps of learning, and I don't have to bring it up all the time, but it's usually when I have a resident who can't shut up, and I have to say, stop. Okay, there's 5 steps of learning. And then they'll still talk. I said, stop. Okay? All right, so 5 steps of learning are quiet, listen, memory, practice, and teaching others. So if you can make someone else, especially with operating, you can get someone else to, you don't know the operation if you can tell someone else how to do it. If you can make that Bluetooth connection work between your brain and their hands, not a simple task, but it's very, very important. So, let's see. How are we on time?
8:34.
What time do you go to?
Well, usually we're done at about 8:30.
Okay, we can stop here. I left a couple other talks, some other trauma talks that I can go into. I mean, they can be shown anytime. Self-explanatory.
We'll do it part of the session too.
Okay.
Thank you.
All right.